Hi there, I'm the neuromuscular mechanic, and today we're going to be talking about ultrasound guided proximal intersection syndrome injections. So, when I talk about proximal intersection syndrome, that's the condition that arises between the intersection of dorsal compartment 1 and compartment 2. So, patients will often have pain just proximal to the back of the wrist, just proximal to what we see with de Quervain's tenosynovitis, worse with repetitive wrist extension. Now, with any injection, I like to go through a checklist, and we're going to review these things. What's the ideal patient position, transducer? How do I localize my structure through the surface of the skin? And what do I need to see on pre-scan? And what to identify, or how to identify my target prior to an injection? So we'll go through that. With patient positioning, I have patients on their back. If they have no shoulder pain, I'll get their shoulder abducted to 90 degrees with their arm resting on the table with their palm flat against the surface of the table. The transducer that I use, if I can, I will use a high-frequency linear ultrasound probe. Because it's high-frequency linear ultrasound probe, I get the best resolution for superficial structures. So that's what I always use. Then if we talk about surface localization, so I take my ultrasound probe and I put it at the back of the wrist, just proximal to the wrist joint in short axis. And the idea is I want to localize Lister's tubercle. This is a bony prominence, and it's important because just radial to Lister's tubercle will lie the second extensor compartment, which contains the extensor carpi radialis longus and brevis, which play a part in intersection syndrome. It's one of the compartments involved. So once I've identified that second extensor compartment, I can then move the ultrasound probe proximally following that compartment until eventually I'm going to see the first extensor compartment tracking above the second compartment where the intersection is. And many times patients will have pain to sonopalpation at this region with intersection syndrome. Then with my pre-scan, as I've alluded to, I want to be able to identify Lister's tubercle because that'll help me identify the extensor compartments. As I mentioned, the ECRL, ECRB tendon compartment is just radial to Lister's tubercle. For what it's worth, the extensor pollicis longus tendon is just ulnar to Lister's tubercle. And then we want to identify that first compartment, often at the level of the intersection syndrome. The abductor pollicis longus and the extensor pollicis brevis are often more muscle than tendon at this location, for what it's worth. And then once I've identified this intersection, when I do my injection, I do it in plane, often from ulnar to radial, and I'm trying to get the needle and the injectate in between the two compartments. I don't want to be in the tendon. I want to be in between the two compartments, and we'll go through that. So here I'm going to show you an ultrasound of myself. So here we go. I'm going to pause. I've got the ultrasound in short axis, just proximal to my wrist joint. And this bony prominence that you see here that I've labeled with LT is Lister's tubercle. That is the home base. And what I'm going to do is I'm going to use this to show the sort of surrounding extensor compartments. So in a second here, what I'm going to do is I'm going to be extending my thumb at the IP joint of the thumb. And there, what you're trying to see or visualize is movement of this structure here, which is the extensor pollicis longus tendon, which lies just ulnar to Lister's tubercle. Then what I'm going to do is I'm going to translate my probe just slightly radially. So I'm going slightly radially. We're losing Lister's tubercle, but there's my second extensor compartment, which is just radial to Lister's tubercle. That's the ECRL and ECRB tendons. And so because this is part of intersection syndrome, I've localized it, but I've localized it distal to where intersection syndrome is. So now I'm going to take that ultrasound probe and I'm going to translate proximally following that compartment. And as I do right there, you're going to see this hypoechoic structure running over that second compartment. And that hypoechoic structure are the contents of that first compartment. So the abductor pollicis longus and the extensor pollicis brevis, which make up that first compartment. At this level, you'll see that the structure is mainly hypoechoic. There's a little hyperechogenicity sort of to the inferior aspect, but at this level, that first compartment is mainly muscle. And so what I'm going to do here in the next sort of series of clips is I'm just going to be moving the probe distally and proximally just so you can appreciate the first compartment going over the second compartment as you see there. And then if we come back up and we pause, if I was going to do the injection, if we think of that red arrow as my needle pathway, I would bring it in plane in this image from ulnar to radial, and I'm trying to bring that needle just above that deep second extensor compartment. So I'm trying to put that injectate above the second extensor compartment, but below the APL and EPV muscle. So that's where I'm trying to put it. And again, just moving things to show that intersection. So that concludes the videos today. I'm the neuromuscular mechanic, and I hope you found today handy. Take care.